Okay, thank you both very much. I love how that was focused on how trainees can be involved in research as well as being investigated by research. We have our first question, which is from Benson. If you want to, I think, unmute and ask, that'd be great. And you're all welcome to turn on your videos so we can see your faces if you care to.
Hi there. My name is Benson Lee, and I'm a rising MS2 at Upstate Medical University. Thank you both for your presentations. My question revolves around shift work. Specifically, I've always wondered why hospital shifts are 24 to 36 hours long, if studies have shown that medical errors occur usually at the end of shifts due to sheer tiredness. Given that, I've also been told that long shifts means fewer handovers and thus reduces overall medical errors. Can you guys comment on whether this is true regarding why there are such long shifts?
Dr. Huffmyer, did you want to speak to this?
You know, as far as why there are such long shifts, I think in medicine, it's, you know, residents were named residents. Why? Because they lived in the hospital. They essentially provided care around the clock to hospitalized patients. And I think, you know, it's interesting over time with the increase of advanced practice providers, so nurse practitioners, nurse anesthetists, physician assistants, that has really helped enable residents, obviously, to work shorter hours and to have a little bit more control of life and lifestyle and the amount of time that's worked. I think that that for many institutions, and this is getting into an area that I don't know a lot about necessarily, so take this with a grain of salt. You know, it's not inexpensive to hire a lot of advanced practice providers, right? And it's hard also to have enough residents, so to cover everything. And so I think that the balance, you know, over time has been 24 plus 4 as far as the maximum number of hours that a resident can spend in the hospital, and that's kind of that's an ACGME practice. Several years ago, there was a revision in the requirements for duty hours, and so one of the things that happened is they said that the least number of hours, or the most number of hours that an intern can spend in the hospital is 16, and they had to have 8 hours off per shift. And what happened with that is that it ended up being that those interns didn't actually work more hours total in the week, and they never got a post-call day, so they ended up spending a lot of time at the hospital. There were a lot more handoffs of care, and they weren't actually any more rested. And so that's why there was a revision in 2017 to go back to allowing 24 plus 4 with a post-call day. So it's a balancing act, and it's a lot more than hours worked and handoffs. You know, I mean, I think it's important to understand that there are business decisions that kind of work into this. So, Dr. Riesenberg.
It is very complicated, but things have changed a great deal after Libby Zion died. Duty hours actually have been reduced significantly from the way they were before. And there are lots of studies that are actually looking at this question, the balance between number of hours worked and handoffs. It is true that when you decrease hours, you will increase handoffs, and when you increase handoffs, you will increase errors. We don't know for sure, that we don't have an answer, a clear answer on what's the magic tipping point for maximizing length of time and decreasing errors, either with the length of the duty hours or the number of handoffs. But good question. Thank you, Benson.
I think one other point I wanted to make along with that is that when residents work more shift work, they have kind of more maximal control of their life, maybe 10 or 12-hour shifts, but they often feel like they don't know the patients as well. The continuity of care is not as robust. And so that's also an issue that residents have faced over time.
Thank you.
Benson, that was a great question, and I love that it addressed both of our speakers today. Surely you all have some questions. I want to encourage you to just type something down on that chat so I can call on you. Maybe I will ask a question as well. I'm curious. Sometimes I think there's a view that there's sort of degrees of a desirableness of research, and, you know, basic science is somehow the gold standard, and then there's clinical research, and education research can sometimes be treated as sort of a stepchild. I'm curious, have you gotten pushback? Like, why are you doing this education research? How did you deal with that? How did you overcome it? Why did you follow this as your passion in research?
Dr. Riesenberg, you want to go first?
Yeah, very good. Well, I just love medical education. I've worked in medical education for 30 years, and so it's my passion. And it's just me. I really, really care about how we teach. And so I never really had a question about what I was going to do. It was just always the focus, the passion of my life. And as far as being hard, it is difficult, but there are a lot of things in life that are difficult. Being a female in a male-dominated profession is difficult. Being a person of color it may be difficult. There are lots of challenges that we all face. And it's wonderful to be an expert that people turn to. And once you've established yourself, people will turn to you.
I think to that question, I think there's so many things in anesthesiology, and of course that's my focus. It's not just all of medical education. I think that there's so many things that have been worked out. There are lots of things that still remain to be worked out and researched. I think that there's just such a need for it. I appreciate also the support that groups like FAIR and the ABA give to education researchers. It's very, very important, and it actually helps focus, I think, investigators on, you know, what can be done and opportunities that you can achieve. Raised by two teachers, very reasonable, normal upbringing. I mean, now it would be considered kind of very low middle class, if that, now. But, education was always important. I loved school. It was like everything to me. And I think that the way that students and we change over time, the way we learn and how that changes over time is incredibly interesting. And I never would have thought about it, 20 years ago, about being an adult learner and how that's different and what I needed to do differently. But I'll tell you what, when I went from being an ICU nurse back into medical school, and I had only been an ICU nurse for 3 years, and I jumped back into medical school, and nobody seemed to care that I had been a nurse and had clinical experience, of course. I was faced with doing courses that were quite challenging and rigorous, and I was like, wow, I'm a little bit, I just don't know how to study, or I don't know how to grasp all of this information. And so I think that one of the things I learned through that process is, gosh, we need to do a better job, teaching people how they learn, and maybe making suggestions that what you think feels good or makes you satisfied. Oh, I think I really learned that. You might not have really learned that well enough to be able to retain it, 3 and 6 and 12 months later.
Great answers. I will also say I really like this session because I think it, as medical students, I think you probably hear a lot of things about what you should do, what's required to be successful. This is the one true path. And I think what's really important is not to necessarily, I mean, of course you want to listen to your mentors. I don't want to undermine them in any way, but really you need to listen to your own North Star. You need to figure out what is it that you are interested in, and you'll be much more successful if you are following something that you're passionate about than if you're trying to do something because people tell you that's the hot new thing. So, you know, I just think this is a great example of you can do fabulous work in almost any area. There's lots of untapped opportunities in anesthesiology research, and so you should focus on it. And now we have a question from Krupa.
Hi, I'm Krupa George. I'm a rising MS2 at Texas Tech in El Paso. So our school has actually been doing team steps in kind of like a standardized interprofessional communications training. And so one of the things that we learned was this mnemonic for handoffs called I pass the baton. And like each letter kind of tells you a piece of information to share while doing handoffs. And I was just wondering what your perspectives are on that, and having like a standardized mnemonic type thing to be taught across like all the medical schools, and at what level of training that would be appropriate to start teaching.
Well, I'll start answering this one. Actually, IPASS is an amazing mnemonic. It's we've done a lot of research on mnemonics, and there's very little evidence that any of them work except IPASS. They've actually done multiple studies. They've published 20 articles. They've done a lot. So IPASS actually has data behind it. It was developed for peds. So, you know, using it in other areas has sometimes been challenging. But your question is really about structure. And everybody, Joint Commission in 2006, ACGME, our accrediting body for graduate medical education, AAMC for medical students, World Health Organization, the IHI, all of these places all say we have to have structured, standardized handoffs. So first of all, a mnemonic is a great memory aid. It will help you to remember what the things are you need to convey. That is an excellent tool. But you must have flexible standardization, because you won't always be able to do everything. And you have to find a balance between too much information, because then nobody's going to listen to you, and too little information, because then there will be mistakes made. So you have to find that balancing act. You have to learn to do that. And you're going to take a patient from the OR to the ICU when another patient in the ICU is crashing. And that means that you'll have to condense your handoff. You'll have to figure out what are the most important things I have to convey on this patient, while these providers need to take care of another patient. So there has to be both a balance that you use all the time, and a flexibility that you've developed to know what to include when. So great question, thank you. Dr. Huffmyer, do you want to add something?
Not necessarily. We use the IPASS here at UVA. I was looking at my name badge because I think it's on the back. It's printed on the back of everyone's name badge, as a handy tool to remember. One of the things that I take most of my patients to the ICU, of course, and one of the things that has kind of contributed to us, I think, improving handoff, or improving the missteps from handoffs, is faculty transport every patient with our residents to the ICU, and at the head of each bed is the handoff of care. The handoff of care process is posted at the head of each bed. And so we don't start until the receiving ICU physician is present, and the whole team is ready to go. And sometimes that leads to a little bit of a, increasing turnover time in the main operating room, which is also associated with frustration. But we don't start the handoff until everyone's there and everybody's ready to listen. I think the pediatric groups, I don't do pediatrics, of course, but they have they take a little longer time, and it just expected that it just takes time. Whereas the faculty group, the adult group is generally speaking very straightforward, unless, like you said, another patient's crashing. So it has worked very well here. Having an established way of doing it, and everybody just gets the same teaching, and as much as we can follows it.
Excellent answers. Sure. Oh, wait. All right. No. I like the thank you. I need a question. You got to have questions. I just pointed out we've got a program director on. We've got someone who mentors medical students on. Your questions don't necessarily have to relate to their research and education. They can be broadly on anything. I think maybe we need more questions. Everybody's very quiet today.
One of the things I was going to say, I didn't, I didn't start out in anesthesia residency interested in, pursuing a research career. And I honestly didn't even know that I would end up in academics. And when I said, I think used to be everybody would tell you, you say yes to everything and figure out a way to get it done. And I did that. I've done that for a lot of my career, and it's not necessarily the best way. But I think one of the things that happened though early in residency is that a faculty member said, "Hey, would you like to write this paper with me?" And I said, okay, sure. And it was a very formative, very, very good experience. And I learned a lot. And honestly, that is probably one of the things just that opened the door just a little bit for me. And to see that, look, this is doable, you can do this. There are people who want you to succeed and want you to do well. And I think so I know I said, say yes and figure out a way to get it done essentially, but you've got to be smart about that when you have too many things. But the other pieces that Dr. Huff mentioned was passion. And I really strongly believe in that. And if you are uncertain as to what you want to choose for residency, don't worry, don't panic. There's time, and you have plenty of time to work for the rest of your life on doing whatever it is that you're passionate about. And the world is open to you, and that's the thing. I know medical students tend to be real anxious about what they're going to choose and what the next thing is and the next thing. It will come.
And speaking of that, Shri has a question.
Hi, thank you for this presentation. It was really interesting to see how education research is validated and how you're able to find residents to take on research projects and also be in research projects. I think that my question revolves around outcomes in research. In clinical research, we talk a lot about hard outcomes, for example, reducing morbidity, mortality. In education research, do you think that the outcomes that you prioritize, what are some hard outcomes in education research, and how do you come to those outcomes in terms of understanding how to change programs or structure medical education, both at the student and graduate level?
Well,
Go ahead.
Go ahead.
That's a really tough question. There's a lot to unpack there. One of the things that I mentioned is that at least in anesthesiology education research, many of the projects that we see come across a publisher or a journal's editorial board are things that honestly someone may have said, "Oh, that's a great idea, you should write that up," and essentially the project wasn't started in the right way, or the project wasn't designed well from the beginning. So, oh, I had this idea, I want to change something in the way that we educate residents. I'm just going to do it, and then I'll write it up. And so that's a surefire way to not end up with not just a paper that gets published, but with an outcome that's kind of generalizable and useful. So I think that, starting out with a good idea, or even just with a question, like how, starting with a question is incredibly important, and then going from there. I think that you're right, it's hard. There's not a hard outcome like morbidity and mortality in education research. And a lot of it's in the eye of the beholder, as I mentioned a little bit with learner satisfaction and surveys. There are ways to do survey studies that are outstanding. There's ways to have, there are lots and lots of, almost every institution, every academic institution has some kind of department or group that does that helps with survey validation and those kinds of things. So those studies are possible, but they are they just take a little bit more time and thoughts. I think it's easy to do an education research study and use scores, which is essentially what we did with generative retrieval. That this group scored higher. That's an objective outcome. But most of the rest of many of the other studies are a little softer, right? So driving performance in a simulator. So anyway, I'll let Dr. Riesenberg answer.
I thought I would go ahead and answer the question related to handoffs. An easy thing to study is happiness indicator, satisfaction. Did you enjoy the course that we taught you? And a little bit harder is a process measure. Are you actually using the IPASS mnemonic that we taught you? Do you use it when we observe? Do you use it when we don't observe? Those process measures are a little bit harder to do. They take more time and effort, but they give us more information about the handoff. But what we really care about with handoffs is decreasing adverse events, medical errors. And the only group that's actually looked at that is the IPASS group. They've actually implemented IPASS and then looked at adverse events, and in their study, they actually found that they were able to reduce handoff errors using IPASS. However, caveat, in subsequent studies, there have been questions about whether that's actually a long-lasting effect. You can change behavior short-term, but can you keep it? And that gets into implementation science and leadership change, the culture, what is being supported. So it's a very complex thing. And one of the things that Dr. Huffmyer mentioned earlier is when you actually look at outcomes, you've got to have a large study. So IPASS looked at over 100,000 handoffs in order to get their data. And most of us are in the situation where we're looking at the group of residents or medical students in front of us and don't have enough money to follow them for years and years and years. So it's a trade-off.
So I'm noting that we are at time. So I want to give everyone freedom to leave. Dr. Riesenberg and Dr. Huffmyer, can you stay for a few minutes? We've got a few more questions.
Sure.
Fabulous. So medical students, first I'm going to say thank you to both of our fabulous speakers before we go over time. Medical students, feel free to leave if you need to leave, but feel free to stay on if you want to hear the answers. Nelson, you are our next question. Oh, let me just remind everybody that our next session is Thursday at 11 Eastern Time. It's a journal club on devices, which I think will be fantastic. So our next question is Nelson.
Hello, can you hear me?
Yes.
Okay, great. Well, first off, great presentation. So basically I have two questions. The first one is basically what are some characters that as a program director for Dr. Huffmyer, what are some characters that you're looking for for residents? And the second one is with coronavirus. There's a shift now with virtual interviews. What do you recommend being a program director for MS4 who's applying for the cycle, how can he prepare himself for this interview season, and how can he know, you know, this program is the right fit because everything is planning to be virtual?
Yeah, this is a really, really challenging time to be a medical student. It's a challenging time to be a program director in so many ways. So everybody has similar concerns, but maybe different directions. So the characteristics that we look for in students who are applying to residency: maturity, yes, and intellectual ability, and you know, and so I know someone else has a question about scores, and scores are important to a certain extent, but they're only a very small piece of the puzzle. One of the things that I tell all of our medical students at UVA when I meet them is, look, I'm more interested in how you performed in medicine and surgery in your third year than I am in whether you got a 235 or a 255 on step 2. And the reason that that's important is when you're a third year medical student, that's kind of the hardest year as far as you're having to come to work every day and function. And you have to take a test, you have to take a shelf exam. And so that gives us an idea of how you're going to perform when you're in residency with the pressures and the stresses of coming to work every day and taking care of sick patients every day. Medicine and surgery are the rotations where you have to carry the kind of the heaviest burden or the heaviest load of patients, and again take that shelf test. And so you know, that's why I like to see medical school performance, and sometimes even out of proportion to the step 1 and step 2 scores. You know, interest in the specialty is also important, and a lot of people are kind of like, well, I don't have any research, and I'm like, that's okay, right? Interest in the specialty. Have you been a member of your medical school's anesthesia interest group? Have you attempted to get involved in the department that you're seeking to be in? And so I think that you know, maturity, being bright, interest, and honestly, hard work goes a whole long way, and that's hard to show. But those are some of the things that we look for. I love to ask a question about teamwork whenever I interview. Teamwork, I think, you know, one of the things we see in residency is, you know, you don't know when professionalism is present because you expect it, but you know when professionalism is absent or is lacking. And so I think that those kinds of things are very, very important to demonstrate as you approach this process. I think you asked about coronavirus and how things are going to change. I think that it's going to be challenging for you guys as fourth-year medical students to get through the virtual interview process. There are some tips and so on and so forth online about how to best present yourself. Obviously, a lot of our residents have been through fellowship interviews in a virtual fashion this past spring, and so if you search around your medical schools and your anesthesia departments or other departments that have fellows, you will find people who have done virtual interviews. I think taking them seriously and not, I would dress as you would normally dress, and I know that's simple and it's ridiculous potentially that I'm mentioning it, but dress as you would normally dress when you were going to an interview. A lot of people say people are going to wear shorts on the bottom and a tie and shirt on the top. Just dress in your professional gear, because that will help you behave in a more professional way and take it seriously. I think that it's very difficult to show you know, your interest, your engagement virtually. For folks who sit back and who are a little quieter and more reticent, have a hard time speaking up, that they may have to behave in a way that seems almost aggressive to you, because you're not used to speaking out. I think that that's going to be very challenging. I think you've got to, you have to have questions prepared, ready for each for each program that you interview at. And obviously the internet sites for each of the programs should be, you know, a really great place for you to find out information. All of the programs that you interview at really should still be able to provide you so time with residents that's not, that faculty are not present, and that a coordinator is not present. If they don't do that, that to me is a red flag. And so and it's a lot harder virtually, because who's running the virtual session? And so that's one of the things that we're planning is potentially the night before some kind of virtual happy hour. It's hard because you're like, well, I'm not going to drink on the virtual happy hour, and that's probably appropriate. But I think, you know, join those experiences as much as you possibly can and find out from the residents, you know, about what their lives are like and what they think of their program.
Thank you so much, Dr. Huffmyer. Dr. Riesenberg, I don't have any thoughts on that process.
So I was just going to add that there are some good news things. We've actually been encouraged to move to this. It will cost a lot less for everyone to interview. And we're all in the same boat. We actually are all, we all transitioned to remote interviewing during our fellowships interviews. So we have a little bit of experience, but it just started in March. Mid-March is when I learned how to use Zoom. It was really my first exposure to all of this, and managing breakout rooms and all the things that we had to learn was pretty overwhelming, but we did it. We're all learning how to do it. You're going to be learning at the same time. So that's good. We're all on the even playing field. I think something that Dr. Huffmyer mentioned, and she's of course a program director, so much more important than I am in this, but background research will be very important. I can tell you that it makes a big difference when I'm interviewing somebody if they know something about me and my research and actually can speak to me. And ask me a question that's relevant, right? Yeah. That background research is very important, and you need to do the research about the city, because you need to be able to say, yes, this is a good fit for me and why it's a good fit. And then the final thing is that you're poised in a great position now to actually get good recommendation letters, and they're going to be important. So focus on them now while you have time to make sure that you get good recommendation letters from your faculty.
And we have a question from Thomas on a not in any way controversial topic.
Hi, Dr. Huffmyer and Riesenberg. Thank you guys for your talk. My name is Thomas. I am a second year at St. Louis University. So I guess the first part of the question is more for how do I advise like incoming first years, which is with step scores being moved to pass-fail for them. What are the things that perhaps you guys think we should focus on or are looking for us to focus on? And then on the other side, like with the COVID complications, what are things we perhaps need to focus on and can focus on more in terms of like opportunities and just clinical learning that perhaps will help us prepare us for any sort of residency, and perhaps specifically anesthesia in this case.
Right. I think so. Pass fail. That it's going to be very, very interesting. Honestly, my biggest concern is if step 2 eventually becomes pass fail, because that'll be very, very challenging. That'll be even more challenging. I think that, you know, the most important thing you can do when you're in the first couple of years of medical school is do your very best to learn what you can and to really, really assimilate it into your knowledge bank, right? To give it your best shot, like not to just do it to get a grade, not to just check the box, but so that you can become the best physician you can be in 2 years from then. And I think if I had you know, even myself, I took it pretty seriously, but I think if I had approached it like that, I might have thought about things differently because it's kind of overwhelming and you're like, I got to just do this. I got to do this. I got to do that. You know, you're just checking boxes a lot. So, you know, taking your first couple of years and very seriously, and then doing your best on the exam to pass the exam. You would certainly not want to fail. I think, you know, getting involved in some other activities, and this is the perfect example of one, obviously, a very, very wonderful thing to have on your CV, but you're going to need some extra stuff on your CV potentially, right? Are there volunteer groups in your medical school that you're interested in? Is there a way that you can show outreach? Is there a way that you can show your seriousness as far as being a medical student and then ultimately being a doctor? How do you, you know, how you conduct yourself as a medical student, I can almost guarantee it will be the way you conduct yourself as a resident. I mean, things don't change that much. And so that's one of the things I look for, is that what's this person like on the outside? What else do they do? So as far as I think what was the other question as far as scheduling? Did someone ask something about scheduling? I'm sorry.
So as second years and well, for the third years especially, they had a lot of issues with like the COVID
Yes.
and schedule for their step ones.
Yes.
So is there going to be a bit of a, I guess, different considerations involved with the whole process, or more emphasis on other things perhaps, or what are the things that are
well, I mean, I think we all have to be a lot more flexible this year. I know that some of our students have not been able to take step 2 yet. I think that the deadlines being kind of pushed along are very helpful. I think that medical school, medical education in the undergraduates, which you guys are as medical students, very, very helped along by simulation. And you know, a lot of our third-year students, our third-year students are back in the clinical environment, but they're being helped a lot by simulation, because that's a place where we can control your exposure a little bit better. And so, you know, I would look for those kinds of opportunities. And then one of the things that Dr. Riesenberg said about getting letters of recommendation, as you go along, look for opportunities to shine, look for opportunities to develop good, strong relationships with your faculty that on various rotations. When someone comes to me and tells me they want to do anesthesia, and they're like, well, I want to get 4 anesthesia letters. And I'm like, I don't care. I don't want 4 anesthesia letters, right? I want to see that you have, you know, had a long-term relationship with someone who can speak for who you are, not for what you did for 2 or 4 or 6 weeks. So develop those strong relationships now with other faculty that can vouch for you in 2 years. So I think everyone has to be flexible, including students, including us. And I think things will kind of, I think things will go really well. I mean, the cost thing that mentioned by Dr. Riesenberg is huge for both programs and for students.
Particularly at a time when everyone's a little lower on the income page. Nelson has a question related to this. Go ahead, Nelson.
Yes, so basically with the Step 2 CS being canceled for now 12 to 18 months due to coronavirus, are students that weren't able to take it due to its cancellation be disadvantaged this cycle compared to students who already took it before March?
No way. Don't worry.
Fantastic. Thank you.
All right. I want to thank our fabulous presenters. Thank you for representing educational research so amazingly well. I want to thank our students for hanging in there and joining us, even though I know your lives are changing since the beginning of this program. And also to the students who stepped up and asked questions. Dr. Huffmyer, you mentioned tips online. I'm hopeful you can send us a link and we'll send that out to the students. I will tell you that I think your mentors for your mentor groups probably can answer a lot of these questions about how am I applying to residency. I know lots of people have them. One thing to remember is everybody's in the same boat. So, you know, it's really, I will say what we look at is, sure, we look at scores. That is not the only determinant of what happens. What we really want to know is about the student as a whole. So I think Dr. Huffmyer and Dr. Riesenberg made great points on that. And thank you all, and we will see you on Thursday.